Good evening, delegates. Thank you for joining Shield Connect and happy Raksha Bandhan to everyone. And today we are back with our famous series Icons in the conversation with Dr. Ritu on Shield Connect. And today's topic is CA vulva, that is cancer of vulva. And the topic is going to be taken by our icon for the day, Dr. Rashri D. Katke. So before we start with the session, let me give a little introduction of our speaker as well as host, Dr. Ritu Santwani, ma'am. Ma'am is ma'am is obstetrician and gynecologist, and IVF specialist and founder and CEO of 360-degree Healthcare Studio. And ma'am is also consultant in Amdar Multiple Specialty Hospital, Pune, and co-founder of MAAM, board member of WSCG. And today's our icon is Dr. Rashri D. Katke. Ma'am is professor and head of the unit in Grant Government Medical College, Mumbai. Ma'am is a medical teacher for both undergraduate and postgraduate medical students for 24 years. Ma'am has published 100 plus publications, 250 plus citations in national and international journals, and 1 lakh plus global reads. So we welcome ma'am on our platform for today's session. And I hand over the session to Dr. Ritu Santwani, ma'am. Thank you, everyone.
Yeah, thank you, Nishan.
Thank you, ma'am.
A very warm welcome to my dear friend, Dr. Rajeshri Katke. Madam has taken last week a very enlightening lecture on the borderline ovarian tumors, for which I receive a lot of appreciation across the geography. So we are very grateful. We all academic bodies are very, very grateful to Madam that she has accepted our invitation for today to enlighten us about the CA vulva. So none other than Madam is the master for this oncosurgeries. So thank you, Dr. Rajeshri, once again, from the bottom of my heart for accepting our invitation. And today the Madam is going to enlighten us about the CA vulva. I am able to see so many friends have joined from across the geography. So very warm welcome to all of you. I am actually on the midway, will be joining again within 5 minutes. I will reach in 5 minutes. Yes. So you please start. Yeah.
Thank you so much, Dr. Ritu. She herself is a very amazing person and a great academician, great IVF specialist. And thank you, Nishant, both of you for the kind words. And I'll just share my screen. Today's topic is CA vulva. So 1 minute, I'll go with the slideshow.
Yes, ma'am. It is visible.
Is it visible?
Yes, ma'am.
Yes, okay.
Yes, visible. Yeah.
1 minute, I'll just take the laser point. Okay.
Dr. Rajeshri, just before you start, I have got some messages from some doctors from the Arab countries. They want to know regarding this CA vulva, that what's the role of the initial biopsy. So once you finish, please, we will focus on that also.
Sure.
Please continue.
Yes. So CA vulva, let us see about the incidence. It is cancer is a disease affecting predominantly the elderly women, but we are still seeing with the changing epidemiology, even at the ages of the 40 years also, 5% of the female genital cancers, which it contributes for the women. What are the objectives why we should go for the CA vulva also, to promote a uniformly high standard of care for women with a vulval cancer. And that is very important because physically and psychologically also these women, they are very much, in need of help and disturbed. Then second is to define the standard approaches of treatment. This is very, very important nowadays because there is so much of the, improvement in the technologies and innovation in the technologies, so that the standard approaches you should know in that, to encourage the gynecological oncologists to develop and participate in the clinical trials involving in new approaches of the management and to establish the audible standards. So this is how one should look towards the topic. So what are the causes of the vulval cancer? Two independent pathways of the vulvar carcinogenesis are felt to currently exist. One is a mucosal HPV, human papilloma virus infection. Second is a chronic inflammatory, that is a vulvar dystrophy and with the autoimmune processes. What are the risk factors? Let's look at older age, but now the age is also shifting. Sometimes you can get it at the age of 40 to 65 years of the this thing. Precancerous changes, that is a dysplasia in a vulvar tissue. The lichen sclerosis, which causes the persisting itching and scarring of the vulva. Human papilloma virus 16, 18, 31, 33 types we know in cases of the CS cervix and the CIN. So what are the nice guidelines? That is a National Institute of this excellence. So when to suspect CA vulva, an explained vulval lump is there, an urgent referral within 2 weeks of the wait for the give antibiotic, anti-inflammatory. If it doesn't get results, again you should suspicion of that what it could be. Vulval bleeding due to ulceration within 2 weeks wait schedule, and persistent pruritus or pain at vulva. So let's have a look, because this is the one HPV, association of the HPV DNA with the CA vulva. We are established the HPV DNA much more in the cases of the CA cervix, but HPV DNA was identified by PCR in 48% of the explored cases, of which the 96% were from subtypes of 16 and 18. An estimated 80% of the untreated women suffering from the VIN-3 develop the invasive vulvar cancer. So, and this HPV, which occurs in a younger patients at the age of 35 to 65. So it is very important to know the status, or it is one of the cause of that. Approximately 15% of the vulvar cancers develop in women under the age of the 40. Then condylomata, sexually transmitted infections in the past, low socioeconomic status, or the nicotine abuse have also been found in that. So VNAD. VNAD is a vulval cancer, include vulvar non-neoplastic epithelial disorders. It comes in an advanced age that lead to cellular atypia and eventually to the cancer. The elderly patients are the one which this group compromises more with the VNAD, that is 55 to 85 years of the age. In particular, show a low rate of HPV infection and consequently seldom any associated with the cervical neoplasia. Diabetes mellitus, hypertension just contribute in obesity. The lichen sclerosis, a subgroup of VNAD, is mooted as a predisposing risk factor in the development of the HPV negative vulvar cancer. So there are one which is associated with HPV and which are not associated with the HPV infection. So what are the signs, symptoms? There is a lump or the growth on the vulva, changes in the vulval skin such as color changes or growths that look like a wart or the ulcer, and itching in the vulval area that does not go away. Then bleeding, some ulcerated part, they give the bleeding. The tenderness in the vulval area. Cancer of the vagina or cervix, it is extending to the CA vulva. Heavy cigarette smoking, chronic granulomatous disease, hereditary disease that impairs the immune system. That is one of the things. Then erythroplasia of Curette. So let's have a look why we are, it's little bit of different from the other malignancies and why we should worry about this. And this is very important when you talk with the CNE malignancies, the lymphatic spread and the lymph nodes distribution. So here, if you look about these inguinal ligaments, so these are the superficial inguinal lymph nodes, and these are the femoral or the deep inguinal lymph nodes with the fossa ovalis and all this. See, with this directly this deep femoral nodes, it goes to the external iliac nodes and then internal iliac, and then it goes to the para-aortic. So this is how is the distribution of that, because it gives the importance in the staging of the malignancy, investigation and the management of that. Then lymphatic drainage. See, this is a very important thing is to know that the labia majora, which is the major part of that, the anterior half goes to the opposite side of the mons pubis, so superficial inguinal. So there is a cross lymphatic drainage that gives the very difficult things to in the management, and the midline situation, it gives the extensive involvement of the lymph nodes, or sometimes it becomes very difficult to come to know that which side it is coming. So labia majora, anterior half to the opposite. Posterior half, it goes to the first superficial inguinal lymph node, then deep, then external iliac, internal iliac, and para-aortic. Labia minora and the prepuce of the clitoris, it is a bilateral superficial inguinal lymph node. And the glans and the clitoris, it goes to directly to deep inguinal lymph node and the external iliac. That's why the prognosis is not very good in that. So this is very important we should know where the growth is there and at what side is that, whether it is a majora, minora, and the glans and the clitoris. So lymphatic drainage, if you can see in that how it is going to go into the, this is from the femoral type inguinal, superficial and deep inguinal, and they are going directly to the iliac lymph nodes here, and external, internal, and the common iliac, and then goes to the para-aortic. So very nicely shown in the diagram. Then comes to the staging. We have seen how the patient is presenting, what are the risk factors, what is the pathological things, and how the staging. So stage 1 is tumor 1 is confined to the vulva. 1A lesions, that is less than 2 centimeter in size, confined to the vulva or the perineum, and with stromal invasion less than 1 mm. No nodal metastasis. See, this is a very important thing. If the patient comes to you early in a 1A, where you will have a less than 2 centimeter size of the tumor and less than 1 millimeter of the invasion and no nodal metastasis. That is stage 1. Then 1B, more than 2 centimeter, stromal invasion more than 1 millimeter, and their nodes could be negative. Then comes to the stage 2, tumor of any size, extension to the adjacent perineal structure. This is very important because in the vicinity, there are the very important structures like a urethra, vagina, anus, perineum, and the nodes, where it goes to in a stage 2. Tumor of any size with or without extension of to the adjacent perineal structures, 1/3 of the lower urethra and 1/3 of the lower vagina and the anus, with positive inguinofemoral lymph nodes. So stage 2 is little bit, with involvement with the lymphatics and adjacent structures. Stage 3A with 1 lymph node metastasis or 1 to 2 lymph node metastasis. Then 3B more than 2 or with 2 or more than 2. Then stage 3C with positive nodes with extracapsular spread. This is again very important thing, where the growth ruptures through the capsule of the lymph node and the tumor invades into the regional thing like upper urethra, 2/3 of the upper vagina, or the distant structures. So stage 4, ultimately stage 4 is the stage where you will get upper urethral, vaginal mucosa, bladder mucosa, rectal mucosa, or fixed to the pelvic bone, fixed ulcerating inguinofemoral lymph nodes, and 4B with the distant metastasis. So what are the things in our hand is to diagnose it early in a stages of 1A, 1B, and minimally at the stage 2, because stage 3, 4, it goes with the extensive poor prognosis. So this is, everybody knows in that. This is for the TX is for the primary tumor, cannot be assessed. T1A is less than, just I explained to, but this is the complete thing. We should look for the TNM classification and the regional of the lymph nodes. Then how the spread occurs. One is the contiguity with the direct extension to the adjacent structures, because most of the structures, they are lying in the vicinity of that, like a urethra, anus, perineum, vagina, and the other structure. Then embolization of the inguinal and the femoral nodes by the hematogenous or the lymphatic spread. About 30% of the women with operable disease have nodal spread. The worldwide data, though it is not a very common malignancy, but still there are the data and the studies where we are looking. So we should able to know that 30% of the women with operable disease have a nodal spread. Management, how to go ahead with that, incisional biopsy, a biopsy taken with the intent of securing a diagnosis only. An incisional biopsy, it is important to know, diagnose whether that mass or the tumor is coming from the vulva is the this thing. This is it contains the interface between the normal and the abnormal epithelium and be large enough for the pathologist to be able to adequately provide the evidence of the substage. Means when you are doing an incisional biopsy, take it at the point that where the growth is there and some of the normal epithelium has come in that, so they can stage it. Then comes to the diagnosis of the imaging modalities. Definitely, if the growth is there, clinical suspicion, examination, the history, it is very important in that. But with the CT scan, sonography, CT scan, and MRI, CT scan, MRI, and PET CT, that gives the idea about the extensive cases of the advanced diseases Especially the urethral invasion is suspected, and that is very important to know is that because depending upon that, we can stage the patient and treat according to that, because if the urethra is involved, you have to be very careful while doing the surgery. So this is how to take the biopsy. Okay, so we have seen about the incisional biopsy. Then excisional biopsy, a biopsy taken that it includes all the abnormal epithelium but does not provide a tumor-free zone of 1 centimeter in all dimensions. So excisional means only excisional, but it doesn't give the tumor-free zone of 1 centimeter. Okay, so how to go ahead with that? See, this is the this thing. This is the growth in that, and this is a long axis in the axis of the extremely parallel to the lymphatic tissue, and these are the lymphatic vessels. And if suppose if you want to see that, the margin should be around 1 to 3 millimeter, you know, because there should be a healthy margin left in that. So excisional biopsy, where you can say that less than 1 centimeter of the tumor-free margin is there in that. This is what I was explaining there. Abnormal epithelium but does not provide a tumor-free zone of 1 centimeter. What is the radical excision? An excision performed with the intent of achieving clearance of at least 1 centimeter of all aspects of the tumor. See, whenever in oncology, if we are doing it excision, what our idea is that what we should achieve is that apart from the malignant tissue, minimum here they have seen is a 1 centimeter, but I feel 2 centimeter area should be normal of the healthy tissue, and that has to be confirmed with the histopathology, and that is what is called as the tumor-free margin, and that comes into the radical excision. Diagnosis. So we have seen all type of the biopsies. I have just included in it because most of the times people ask about this. That's why. So any change in the vulval epithelium, warts in a postmenopausal woman, or the persistent warts are there, any suspicious lesion is there, lump is there, go for a biopsy. So what are the histological types of the vulval carcinoma? We know more than 90%, 90 to 90% is a squamous. Melanoma is 5%, basal cell is around 2%, Paget's disease less than 1%, and Bartholin, they says it is a rare one. These are the histological things which gives the keratinizing squamous cell carcinoma of the vulva, and transition of normal epithelium to the squamous cell carcinoma of the vulva, where you can see pleomorphism and you can see hyperchromatic nuclei in that this thing. So reporting about this squamous cell carcinoma, most common, the report should describe about the vulval intraepithelial neoplasia, classical type, either grade 1, 2, 3, and VI differentiated type. This is very important because depending upon that, the prognosis of the patient and the 5-year survival rate will be, considered. Assessment of the invasion. Tumor type according to the WHO classification. See how the tumor differentiation is that we should look for a depth or thickness of the invasion. That gives how much the tumor has gone into the depth. Presence or absence of the lymphovascular invasion is very important in that, because if it present, that will go into the abnormal, that will go into the poor prognosis. Or presence or absence of non-neoplastic epithelial disease. So in case of the excision of the specimens, okay. So if suppose you has excised the specimen, assessment of the margins, which is very, very important. Every time we do it, I always see that because whenever we are operating the vulva also, you have to do the marking and you have to assess about the margins. So what is about that distance to the epithelial resection margin? Suppose tumor is there, then what is the distance to the tumor area and the healthy in that? Distance to the urethral resection margin. This is very important in that, means you cannot take that will I'll come to know afterwards. Distance to the vaginal resection margin, distance to the anal resection margin, distance to the subtissue means deep resection. This thing I'll explain with the this thing in a further. About the involvement of the lymph node. Lymph nodes not involved macroscopically must be examined in their entirety with the nodes larger than 5 millimeter, blocked out at 2 to 3 millimeter. So one important thing, let's come to the ancillary studies, frozen section. Little is of that, but if it is available and if you are in a doubt, you should go for that. Immunohistochemistry is not much of use in even AE3 micrometastasis in the sentinel nodes. So this is about and CK20 or CK7 for the vulval Paget's disease. But Paget's disease, we are not saying it is very commonly in that. So let's have a look about the treatment. See, all these treatment is depend upon the what you can say that stages. So if early stage disease is defined as stage 1 and 2, I explained while explaining the stages that this is the one thing where the tumor is limited and not extensively has been spreaded to the adjacent structure or move to the lymphatic system. So this is a chance where you can diagnose it, take a biopsy, and you can treat the patients properly, and you will get the good result in that. So what will happen? These patients should undergo surgical excision, including the adjuvant treatment based on the findings at the time of the surgery. Means if you see the palpate, the lymph nodes are there under the anesthesia, or if there is extension while doing the one. So ultimately, in stage 1 and 2, we have to go for the surgery. Locally advanced disease is defined as stage in a stage 3 or 4A, where the operative treatment is prepared. No, this is the extensive, and here we have to think of the whether you should operate it with the surgically or we should go for a chemoradiation. Stage 4B disease include women with the distant metastasis. A primary chemotherapy is recommended provided patients are candidates for the systemic treatments. So in order to avoid psychosexual morbidity, a radical wide local excision is possible in the cases of the localized lesion. And this is the one thing. There also some in BOT, I was explaining about the fertility sparing surgeries, but here in CA vulva also, in order to avoid the psychosexual morbidity, you can go for a radical wide local excision, and after that you can go with the radio or chemotherapy. So T1 lesions with no extension to the adjacent perineal structures like a urethra, vagina, or anus might be treated by wide local excision. This operation is effective as radical vulvectomy in preventing the local recurrence. If you feel that something is there, you can again go with the radiation or the chemotherapy. So what are the treatment for the early stage? Radical local excisions, more advanced modified radical excision with sentinel node biopsy, advanced stages radiation plus chemotherapy, and possibly followed by the limited surgery. So recent guidelines in the management of the CA vulva in tumors clinically confined to the vulva or the perineum, radical local excision with a margin of at least 1 centimeter has generally replaced the radical vulvectomy. See why the people they are coming from the radical vulvectomy to with the wide local excision is that with the radical vulvectomy there will be extensive dissection is needed. Then there is more bleeding. Then there is more lymphatic lymphedema. Chances of the non-healing of the wound is more, chances of sepsis will be more in that. So, and we are having the advancement into the radiotherapy also and chemotherapy. So they are coming with the a limited area of the tumor malignancy in a stage 1 where you can do a wide local excision with 1 centimeter tumor margin free with the healthy tissues, and they should go with the further, if it is anything, they should go with the radiotherapy or the chemotherapy. A separate incision has replaced in block inguinal node dissection. And this is very important in that rather than taking more wide and then continuing the old incisions. And this is very important. Okay. Ipsilateral inguinal node dissection has replaced bilateral dissection for laterally localized tumors, and femoral lymph node dissection has been omitted in many cases. See, here in a CA vulva, the central part and the lateral tumors, we don't know how much it has been spread to the contralateral inguinal nodes and the ipsilateral. If it is positive, the tumors is there, you can go for the ipsilateral inguinal node dissection. And previously people used to do that, but it has been replaced to do with the bilateral dissection of laterally localized tumors. So this is very important to give the good effect for this. See, this is the about the wide local excision. You can see the urethra is there. This is the vagina. Must be if the growth is on the labia majora, the minor, then you can go ahead with the. You can see about this tumor margin. You can go see very nicely. This is the growth in that, and we are going from here, here, here. But this distance to this, it should be a 2 centimeter. And this 2 centimeter, it is a tumor-free margins, and that gives the excellent result with the 5-year survival rate. And about the groin node dissection, then you can go with this incision sites in that. So how we should look in that key, you should see the extent with the clitoris, urethra, vulva, and the vagina and the anal part. So whenever it is the if you are going with the radical vulvectomy, then it includes so much of the big things in that. So people are going into the wide level local excisions. This is from my OT. There was a tumor was there, and I have excised this tumor with the wide local. This is the urethra. I have kept the part of the urethra intact in that, and this you have to do the properly marking of this thing, and then you should do with that. And after that, we have put with this graft in that, and with the help of the plastic surgeon, and they have done grafting afterwards in that. So this is how we have done in that. So whenever this is the thing, when you are going into the malignant of the mass, then you should go. See, this is the part of the tumor, and here is the healthy tissue. So you should go in that plane, so that it should not be the malignant part. It should not remain with the plane of the tissues in that. Okay. This is something, black, if you can appreciate in that. See, because here what we have done is we have I have shown the tumor free margin, the healthy healthy part of that. It's not because of the dark color, it has not come in that. So but you can see that this is the growth, and this is the part where I have taken the margins. This is 2 centimeter, 2 centimeter of, and 2 centimeter of above that. So this is how this is the growth cases in that. This is, I have shown you that this is the urethral opening, and I have cleared all the tumor mass has been taken it out from there, and it has been reflected the tumor mass and the healthy margins. You have to take it very neatly, the incision and everything. I use a pottery to control the bleeding and the bipolar and all, and it has been help in that. And this is how it has been looked after the complete this thing. And this is the specimen from the patient, and we have done this in that, and the notes has been done so in this case, because the nodes, it's bilateral, ipsilateral node was suspicious, so we have done the bilateral inguinal node dissection. Radical vulvectomy implies removal of the entire vulva down to the level of the deep fascia of the thigh, the periosteum of the pubis, and the inferior fascia of the urogenital diaphragm. Tumor-free margin 1 centimeter is required. It's very difficult because you have to take the entire vulva, then medial thigh, periosteum to the deep and all. So nowadays, very rarely people, rather than doing that, people goes into the radiation with the extensive diseases. So the concept of modified radical vulvectomy. So in a modified radical vulvectomy, including the hemivulvectomy, can be performed, which means that only the anterior, posterior, left or right part of the vulva is removed. You have seen just now what we have done the dissection in that. T2 lesions with extension of adjacent peritoneal structure should be treated by the radical vulvectomy or the hemivulvectomy, as mentioned above. Radical, previously people used to do with extensive, but it is to having the lots of morbidity and mortality with the patient. So see, this is about the partial vulvectomy. The area has been removed with the tumor, and that side of this tumor-free margin of 2 centimeter right from the urethral to the anal or the perineal region, whenever it is the tumor is confined to that. But with the radical, the whole vulva, the medial side of the thigh, periosteum, and everything it has to be taken it out. Tumor involves in the urethra. So how we should go ahead with that? If the tumor involves the urethra, the distal 1 centimeter can be excised without affecting the continence. This is very, very important. Even you are doing, suppose it at the upper part, upper vulva, there is a tumor is there and it is being close to in that. What I have shown in my this thing, the tumor was there just near the urethra, and there I have dissected out, and 1 centimeter can be excised without affecting the continence, and the patient was having good control of the urine continence afterwards, after the surgery also. But if you are going more than 1 centimeter, or if you are going to the urethra to be excised in that, then the patient has to be go for the additional exentration surgeries like formation of new bladder and all, and generally means results are not very good with that. So you have to see, and you have to decide how much the spread of the disease is there or not. That is the thing. Plastic surgery is recommended. So what is the role of the plastic surgery? In some cases of the extensive vulval cancer, plastic surgery is recommended for covering the defect. It is a multidisciplinary team working with the plastic surgery colleagues, and we have also done in couple of the cases where the the fasciculated skin flaps has taken from the medial thigh, and we have in a big there is the area is there, then they go for the distant flaps also, like rectus abdominis and gracilis myocutaneous flaps. So in some cases we have done it, so I have included in that. So basically either one should go for the local, but that is the more area of the plastic surgeon, and they go with that actually. So this is what is the role of reconstructive surgeries. What are the secondary intention? If tension-free, direct wound closure is not possible. See, sometime at one place I was giving a talk on this, and many of the gynecologists, they said we do a primary closure or we keep for the secondary intention. If it is a small thing is there, you can close it, but the gaps are so big sometimes, it becomes very difficult in that. Then either you keep for the secondary intention, or the split skin grafts are always better, the consultation with the plastic surgeon. Taken from the buttock or the thigh, and rely on a healthy blood supply from the wound bed to take. That is the one thing, because they are less reliable for following the radiotherapy in a heavily scarred area. So if they are giving with the wound skin grafts is there, if it is a healthy things, then you can take it from the medial thigh, which is from the local, because with the radiotherapy it becomes very difficult because of the heavily scarred area and compromises of the blood vessels. Skin grafts are usually reserved for large areas when there are no flap options to provide adequate soft tissue cover. Then flap coverage. Flaps provide healthy vascularized tissue and do not rely on adequate perfusion from the wound bed. This I have told you. So local flaps are from the rhomboid flaps, lotus petal, or the pudendal thigh flaps. And distance such as the gracilis or the rectus abdominis muscle flaps provide a larger, more bulky reconstruction with a more predictable blood supply. This we have done with the distant flaps also. Then comes to the superficial groin node dissection alone should not be performed. It is always associated with a high risk of a groin node recurrence. Always see whether there is an involvement of the superficial. Superficial always goes with the deep. So not solely with the superficial inguinal lymph nodes. We should not take like that only. And preservation of the long saphenous vein may reduce the both groin wound and the subsequent lower limb problems. And this is very nice. Things which is coming up, because used to be much more in the past year. Inguinofemoral lymphadenectomy. What are the principles? This is very important because the concept has to be cleared. Because many of the people, what they say is what they think that we take a tumor and take from the superficial inguinal lymph node. No, we should not do that actually, because once the capsule is ruptured and we take half of that, half left inside, it spreads and it doesn't give better survival to the patient or the better prognosis. So what are the principles? Inguinofemoral lymphadenectomy is the standard approach for evaluation of the lymph nodes in women with the vulval cancer, because we are having the concept of the sentinel lymph node biopsy. Historically, pelvic lymph nodes were also removed, but with an incidence of 2%. What they want to say is that one should go for the superficial and deep inguinal lymph nodes. Take the biopsy and this. Ideally, one should go for the pelvic also, but pelvic lymph nodes is around, they are lymph nodes involvement is only with the 2% of the cases and extensive diseases. So going so deep and giving the post-operative morbidity is not good for the patient. So go for the inguinofemoral lymphadenectomy and see the histopath report of that. Pelvic lymphadenectomy, it is recommended also, but when 3 or more positive unilateral groin lymph nodes, whether the capsule is ruptured or the macrometastasis is up around 10 millimeter. So first is the inguinofemoral. See for the whether there is a fixity of is there or there is mobility or the capsule has been ruptured or not. Then with the groin biopsies, node biopsies, if you feel that there is a macrometastasis in that, then on table you have to decide in that if supposed to go for the pelvic lymph node. Groin node dissection is performed to assess the nodes for evidence of metastasis, which may indicate the need for further therapy and to help reduce the chance of recurrence of the further metastasis. And this is very important because groin node dissection, if we do good properly, then a further metastasis and recurrence and reoccurrence of the disease will be less. The indication of lymphadenectomy, I have explained. Oh, sorry. What happened? 1 minute.
I think all the slides are coming in display.
1 minute. I'll just.
No problem, no problem.
वो ये हो ये क्या हो गया?
escape का बटन दबाओ आप. हाँ.
अरे वो आ गया.
हाँ आ गया देखो.
Sorry. Yeah. What was my number of slides? Same thing. Okay. Thank you. Bilateral groin node dissection should be performed for the midline tumors and for those involving the anterior labia minora. Large lateral tumor should be probably also have bilateral dissection, and definitely if the ipsilateral nodes are positive. So it is very important. Midline tumors are, they are crossing the lymphatics, both the sides in that, and midline bilateral groin node dissection is very important in that. In lateral tumors, if suppose that side lymph node is positive, then again go for the bilateral one. Then this is very important. One should know sentinel lymph node biopsy is recommended in those patients who have early stages of the vulvar cancer to avoid the operative morbidity that is caused by the inguinofemoral lymphadenectomy. And this is a very good concept. So first you take the biopsy, maybe use in early tumor stage 1 or 2, and after that go for the inguinal lymphadenectomy. So how they go with that? See, this is a sentinel lymph node mapping was originally used. Okay, so with mapping by injecting the radiocolloid or the technetium, isosulfan or the methylene blue, if you feel that the lymph node is suspicious for that, then go for the biopsy. This I will explain very nicely. If the sentinel node is positive, a full inguinofemoral lymphadenectomy followed by postoperative radiation therapy is recommended. See, this is very important. If that node is positive, go for a bilateral inguinofemoral lymphadenectomy and postoperatively see the report of the histopathology and go for the radiation. But if the sentinel lymph node identified by mapping, sometimes with the mapping, you will see the reactivity of the lymph node, but with they are histologically negative on frozen, then no further treatment is indicated. You can keep a watch on that, or you can second stage, you can do the lymphadenectomy also. Even though lymphatic mapping and sentinel node biopsy are accurate, but sometimes what it happens, suppose the mapping and the biopsy, node biopsy, both are negative. So what we feel is that we should not do anything, but that is not the reason, because false negative results are taken into account for the midline tumors. So site of the tumor is very important also in that. If suppose if you have a midline tumor, go for a bilateral inguinofemoral, and after that go for the radiation, this thing. radiation lymph nodes, this we have considered women with a positive groin nodes. Radiation was superior for the better survival rate. Some people, they have a concept of that doing extensive dissection and making the patient morbid, then you can go for the this thing for the radiation for the lymph nodes. So they will have a less chronic lymphedema. Post-operative radiation, what are the things to whom we should go further? One is the lymphovascular invasion. Depth of invasion more than 5 millimeter, margins less than 8 millimeter. You are able to take it out the wide local excision. You could not able to go for the 2 centimeter if it is not possible in that. Yeah, sometimes you have taken, you have seen that macroscopically through your eyes. This is the healthy skin, and afterwards, if you feel that the margins, they are inadequate or on pathology, there is a disease, then go for the post-op radiation. Positive surgical margins, I explained the same thing. Now, more than 1 plus node with extracapsular invasion. So it is very important to know that these are the things where you can go for the post-op radiation. Radiotherapy, primary radiotherapy with or without chemotherapy, advanced vulval cancer. 44 fraction size is important with 1.7 gray being close to the tolerance, depending upon that. But we go for the prophylactic dose of 45 to 50. You have to calculate everything, and the dose has to be given. And second phase of treatment by the electrons means linear accelerator or the this confrontal radiotherapy or brachytherapy. Total dose should be of 65 gray. Indications for, I can't see for that, is actually anorectal, urethral or bladder involvement. Disease that is fixed to the bone, then you can go for the directly to the radiotherapy in that. Chemotherapy, there is role of chemo radiation, because chemotherapy gives the sensitization of the tissues to the radiation. So if it is required, you can go for the alkaloid plant-based cisplatin, fluorouracil, then adriamycin. So this is for the chemoradiotherapy. And regimes, actually cisplatin, fluorouracil using the regime above 40 milligram per meter square weekly. There are the various regimes, but you can go for with the platinum or the alkaloids in that. Then other modalities, the topical immunotherapy, vaccines against HPV, photodynamic therapy, ultrasound surgical aspiration, chemopreventive agents. These are just discussed as a matter of the things in that. So this is a very interesting thing. If somebody is interested in that, I'll just explain. Clinically negative groin examination. Suppose there are no nodes, nothing is there now, even out the ultrasound also, no lymph node. So you don't have to go for the lymphadenectomy. Suppose you in a stage 1, if you have the lymph node, one positive in that, go for a sentinel lymph node biopsy. If it is negative, don't go for the lymphadenectomy. But I have told you that if there is a midline tumor, go for the bilateral IST. Sometimes biopsy is negative and midline tumor is there, then you should go for the lymphadenectomy. If suppose the sentinel lymph node is positive in that, then go for the inguinofemoral lymphadenectomy. And that is to the bilateral one if it is positive in that. And if suppose negative, then you go for the unilateral. And suppose the groin nodes on examination, it is positive, nodal debulking followed by the chemoradiation. So it's very simply explained, and I have again explained on the chart. So comes to the main CA vulva has been the major part we have seen in that. Then comes to the carcinoma of the Bartholin gland. This is also squamous carcinoma or the adenocarcinoma. Proximity to the anal sphincter may necessitate partial resection with the reconstruction. So this is, for the patient goes to the temporary colostomy. It will require the bilateral inguinofemoral lymphadenectomy because of the proximity to the gland to the midline. Okay. So then comes to the third variety, basal cell carcinoma or the varicose carcinoma. Here you have to just do for the wide local excision, and the radiotherapy is preferred in that. Malignant melanoma, I have seen cases also with that, which is a wide, here, they have a very poor prognosis, a wide local excision and block dissection of the groin. That you can do because these are mutating and they are the, rapidly spreading tumor is there. So poor prognosis. What is the morbidity related to surgery? Wound breakdown, wound infection, deep vein thrombosis, pulmonary embolism, pressure sores, introital stenosis, urinary incontinence, rectocele, fecal incontinence, inguinal lymphocyst, lymphedema, and hernia, and the psychosocial complication. So prognosis of patients with vulval cancer is quite good if they are come into the early stages. Inguinal and femoral node involvement is the most significant prognostic factor for the survival. If they are involved, if the capsule is ruptured, if fixity is there, extracapsular growth of the lymph node metastasis is there, overall 5-year survival rate, it comes from 93 to 70% in that. Recurrent lesions in the lymph node, that is also gives a poor prognosis. Screening, let's have a word about the screening. No evidence supports screening in an unselected population. So there are two varieties, only patient present with the symptoms, and you can feel any patch of the color or the chest, what is there, lichen sclerosis is there, or classical undifferentiated HPV associated things with CS surveys. Then one should go for the colposcopy or the diagnosis biopsy, punch biopsy, or the excision biopsy. This is the one from my center. We have done, published one paper of vulval carcinoma survival outcome with an institutional experience. 5-year survival rate, if you can see in our study, was stage 1, 98%, stage 2, 85%, stage 3, 74%, and stage 4 was 31%. So it is quite because the data was a limited one. So in general, if you look for the FIGO staging and FIGO staging with 5-year survival rate, stage 1, 96.4%, stage 2, 87%, stage 3 is 74%, and stage 4 is 35%. And 5-year survival is more better in a stage 1 and 2. So in conclusion, the vulvar cancer is a rare disease. It's not a rare disease, but it is contributing, all women's gynecological malignancies, around 2 to 5% of that. Because of the pathogenesis survey and the radiotherapy are the main treatment of the modalities. The sentinel node biopsy represents a contemporary approach to the vulval cancer treatment and significantly reduces the morbidity. So that is one thing. Improvements in the treatment of the vulval cancer contributed to the decrease of mortality among the women. The surgical treatment is still standard treatment for the vulval cancer depending upon the stages. The development of a minimally invasive surgical technique and sentinel lymph node biopsy revolutionized the treatment and which has given the standard treatment in a selected cases. The replacement of the inguinofemoral lymphadenectomy with this procedure significantly reduced the morbidity and improved the quality of life. Due to the rarity of the vulvar cancer, patients should be treated in a specialized centers where appropriate equipment, knowledge, and experience are available. So with this, I will end my my talk, and thank you very much. So I would like to end with the quote of Abdul Kalam sir: excellence is a continuous process and it is not an accident. So in life, we have to continue with every minute to minute, day to day, and learning is a process. The same thing, excellence is the process with the continuous process. And thank you with the lovely roses to all of you. Thank you very much for hearing patiently.
Thank you, dear Dr. Rajeshri, for giving us a very, very clear presentation. Though I have missed some in between, still because it's raining heavily, my net is not connecting from the laptop. That's why I'm joined from the mobile. But I thoroughly enjoyed your lecture. Wonderful slides, I must say. Dr. Rajeshri, there are 2-3 questions. These are my questions.
Okay.
The pictures you have shown for this, the radical vulvectomy. So what's your experience with these patients for the follow-up with the sexual concerns there? Because these days we are seeing so many patients. Yeah.
If suppose now, standard treatment, they are coming with the localized tumor with the wide localized excision, with if the nodes they are positive, taking it out, and if you do very nicely flap and plastic surgery and all in that, So in that, definitely for every case of CA vulva, you operate, not operate, go for radiation. Definitely there is a, a trauma to the mind of the female, and sexual problems, they are there. But if you can, how we can doing in with the breast reconstructive surgeries in that also. So here, if you give in that, so with the wide local excisions and with the radiation, they are the less problem with the counseling to the patient. That is very important in that. We can say that even with the excision, the femininity doesn't go, the libido, but it reduces also. But they are very much depressed in that. So that counseling is very important. Then involvement of the multidisciplinary people around, with the plastic surgery, reconstruction. And you must have seen in that when I took the incision and dot, my plastic surgeon, he said, what a wonderful 1 centimeter, 1 millimeter here, and there is here and there, it is not there. It was so symmetrical in that,
Great.
so that is how the things in that. And definitely counseling and some of the drugs, so we are not giving in that. So that is very important for her. Exercise, local exercise, perineal exercise, if the tissue edema goes down in that. And definitely many early stages, if the patient has come, they have a very good experience about this. They come out of it, especially the young ones.
Great, great.
Right.
Other query, after this radical vulvectomy, do you see that once
Ritu, we are not now generally people are not doing much of the radical. Radical vulvectomy
Okay.
means the whole vulva has taken medial side of the thigh going to the periosteum, and it is an extensive radical. In that, if suppose such a huge tumor is there, then people go for a radiation or the excision of the tumor, and then go for a chemoradiation in that. So that is,
Okay.
but what we have done is a wide local excision in cases, some of the hemivulvectomy, in some cases the radical vulvectomy was done. But now people, they are changing with this.
Okay, okay. So you have cleared my two questions.
Functional
Yeah.
functional part of the vulva,
Yeah.
if it is possible, healthy tumor-free
Mhm.
margin, if you're keeping and reconstructing it properly and
Mhm.
boosting her, confidence with counseling and with exercise, definitely it gives a good results, good quality of life to them.
Okay, okay. Thank you. Thank you so much. Dr. Nishant, is there any online questions? Because I've logged in from mobile, so I'm not able to see. Dr. Nishant, please check.
But I have explained very nicely with the slides, the practical
Yes, yes.
approaches, the worldwide data, my
Yeah.
experience and all.
Yes.
So
Yes.
definitely, but this will be very, I think, informative
Very
to.
useful. Yeah. Very useful. Very useful. I was thinking only the same. जब हम पढ़ते थे तब आपके जैसा किसी ने क्यों नहीं बताया? Such a self-explanatory slides. Very nice. Very nice. Huh?
I have worked
So,
with the patients also, reading from the books and elaborating is a different phenomenon, and doing it and explaining that experience gives little more understanding for ourselves, and with that explanation, the knowledge is delivered in a different way.
true, true. Very true. Very true. So, I think there are no questions.
What
Just a,
that excisional biopsy you said, na, something
huh?
Arabian.
Yes, yes, yeah. Huh.
So I have explained in that if suppose for the diagnostic purpose, if you're taking the biopsy, then take it from the tumor and a healthy margin of that in that, okay? And suppose this is for the incisional. If you are doing a wide local excision or excisional thing is there, then always go for 2 centimeter or minimum 1 to 1.5 centimeter tumor-free margin, and then you do a wide local excision in that. And third is the radical excision, where you have to do the whole thing is in that with the radical. And generally nowadays with the chemotherapy, it is a very wonderful thing. We have a linear accelerator technology where you are dealing the radiation to the site in that. and if it is required, if inside also brachytherapy or the external beam radiotherapy also, in that it is going to help the patient, because this is not the only one. Oncology is not only one. The thing is that not only the surgeons, the oncologists, the medical oncologists, the radiation oncologists, the psychologists, the physiotherapists, and all these has to be come and try to treat the patient, and that helps into the 5-year survival rate to the quality of life of the patient. That is the score, what we say in that.
Yeah. Thank you once again, Dr. Rajeshri,
Thank you
for
very much.
for explaining such nicely. I think whosoever want to have a revision can go through the YouTube channel and see all the slides. Very beautifully she has explained. So
Yes.
thank you once again from the bottom of my heart.
Yes.
With this,
Thank you everyone.
Dr. Rajeshri, before we wind off, I want that you should give please some message for the new upcoming gynecologists.
I feel,
Yeah,
those who are,
yeah,
those
please.
who are entering into the field of the obstetric and the gynecology, we are dealing with the patients. So whenever it is there, when you are learning, learn wholeheartedly, very dedicatedly, and learn with the ethical principles also, and go to the take the knowledge from the horse's mouth. We should not go with the only with the pocket and the pocket books, and it's like that. This is the one thing. Whenever the knowledge is there, your skill get improved. And I have just put the quote is also, learning itself as a curve. Learning is a process. Excellence is the process, and there is no solution than hard work, sincerity, dedication, and knowledge gaining for the success, in life.
Very
So
true.
be empathetic with the patient. Think patient, they are like, we should always put ourselves or our beloved ones in the place of the patient, and think of the treatment, what we are giving, how it will affect for her 20-25 years of life afterwards also. And if we go through this channel like this, then definitely one day you can excel. And the youngster, I feel that there is always a learning curve, so in that, always respect the learning curve, and you should able to take the so much of the knowledge and the gatherings for the betterment of the patient. Like, service to the patient is like a service to the humanity, service to the God. We are very in a very noble profession, and that too in the obstetric gynecology, you are dealing with the two lives. One is the mother, and the second is the baby in that. And here you have lots of scope in that, and in that we can earn a very because the nature has given the nature has kept us in such a profession that with our work you can gain the satisfaction, and you can gain some punya, so it means good thing also in that. And I am sure every doctor on this planet of the earth, they are doing the excellent things to save the patient's life in that, and hats off to them. And thank you so much, Ritu. You are such a wonderful person, and I have always a very great respect for you, because people who are working for the knowledge sharing, it is a very big thing. It is a very selfless service in that. And now it is very difficult that people want to do the services on the knowledge platform without gaining anything. So you are the real diamond in the field of the academic excellence, and I wish you the huge success again in the future also. And thank you very much for inviting me, and thank you participants, which those who have been listened to me quietly. And thank you Nishant also, and thank you Kamal also. Thank you very much.
Thank you once again, dear Dr. Rajeshri, for such kind words. You have made my day. So yes,
you
we
all that.
yes,
You
you
deserve all.
both are in the same. We all are spreading the knowledge and sharing as much as possible. So friends, with this, we will wind up today's session. So thank you, Nishant, and thank you, Sahiti. Thank you, Chitra. Thank you, Dr.
Thank you,
Prachi.
Anuradha.
And thank you, Shield Health, for providing a platform. Friends,
Thank you, ma'am.
please note for the coming 2 weeks, our session will be on Tuesdays instead of Thursdays. So please stay tuned. We will be joining you again on 16th. We will post the flyers very soon, 16th and 23rd of this month. And till then, bye-bye. Stay tuned. Bye. Thank you. Thank you all.
Please stay blessed.
Bye, ma'am.
Bye. Bye.